Good evening, everyone, and thank you very much for joining us tonight. Just before we start, if you have any technical problems, please let me know through the chat. For now, I'd really like to welcome you all for the EUROGEN webinar program. EUROGEN is one of the 24 ERNs which cover different medical fields, but they all deal with patients with rare disease or complex conditions that require highly specialized healthcare. The aim for us as a network is to try to deliver quicker specialist evaluation, more equitable access to high-quality diagnosis, treatment, and care for those patients with rare urorectal genital disease or complex condition that requires highly specialized surgery. And we do collaborate in education and training, such as with these webinars and an exchange program. For tonight's webinar, I would like to introduce Dr. Sonia Pérez-Bertólez and Dr. Oriol Martín-Solé, who are both consultant at the Department of Pediatric Urology at Hospital Sant Joan de Déu in Barcelona. And just before we start, we would like to start with a few polls to know the audience. So please be ready to select your answer. First question. In case of failure of conservative management, what surgical technique do you use as the first line of treatment for your POM? You have a few more seconds to vote. Now I'll close the poll. And here you can see that 48% has chosen for ureteral reimplantation, then 37% for high pressure balloon dilatation, 9% refluxing ureteral reimplantation, and 4% ureterostomy. 2% would do a double G placement. Thank you very much. Then we'll go to the next question. In case you perform a high pressure balloon dilatation, how long do you keep the double G stent? You have a few more seconds to vote. And here we see that 67% would do that between 1 and 2 months, 13% less than 1 month, 15% more than 2 months, and 6% doesn't use a double G stent. Thank you very much for letting us know.
Good evening, everyone. First of all, I would like to thank the EUROGEN webinar program for the invitation to participate in this webinar. It is a real privilege to collaborate with this European reference network related to rare urogenital diseases and complex conditions. We have no disclosures. This is the schedule of this webinar. We'll do a 30-minute presentation in 2 parts. I will start with a short introduction. Then I will explain the high-pressure balloon dilatation technique step by step. After that, Dr. Oriol Martín-Solé will talk about the predictors of success and failure after balloon dilatation that we found in our last study. And we'll have time at the end for questions and discussion. You can send all your questions and comments through the question portal. So, what is the definition of megaureter? The term megaureter describes a dilated ureter. A normal ureter is less than 5 millimeters wide and is not visible on ultrasound scan. Therefore, a diagnosis of megaureter is made when a wider ureter is seen in the ureterovesical space on an ultrasound of the urinary tract. Which size? There is some controversy. Different authors say different numbers, but usually more than 7 or 8 millimeters from 30 weeks gestation onwards. Megaureters can be classified as obstructed, refluxing, obstructed and refluxing, or neither obstructing nor refluxing, using the International Classification of Smith from 1997, modified by King in 1980. We are going to focus in primary obstructive megaureter. The pathogenesis of primary megaureter is uncertain. It appears to be most commonly due to an abnormality or delay in the development of the muscle in the distal ureter adjacent to the ureterovesical junction at 20 weeks gestation. This results in the formation of an aperistaltic segment, which leads to functional obstruction. Most cases of primary obstructed megaureter are now detected prenatally. Data derived from routine prenatal ultrasound screening point to an incidence of 1 to 1,500 to 1 to 2,000. Megaureter occurs more frequently in males, and the left side is more commonly affected than the right, and 25% of cases have bilateral involvement. Infants with prenatally detected primary megaureter are usually asymptomatic. However, the condition is not always detected prenatally, and some children still present clinically with symptoms of urinary infection, lung pain, hematuria, failure to thrive, abdominal mass, or associated urolithiasis. All babies with prenatal ureteric dilatation should have a postnatal ultrasound scan. Further evaluation consists of avoiding cystoretrography and diuretic rhinography. The avoiding cystoretrography must be performed to exclude reflux and any evidence of ureteral obstruction. Diuretic rhinography is used to diagnose urinary tract obstruction. In our institution, we use MAC3 as a radiotracer and furosemide as the diuretic. Approximately 80% of prenatally detected megaureters resolve spontaneously, so conservative management should be carried out initially. Indications for surgical intervention are initial differential renal function lower than 40%, especially when associated with massive hydroureteronephrosis, and failure of conservative management, breakthrough febrile UTIs, pain, worsening dilatation, or deteriorating differential renal function on serial scans. So, which is the intervention of choice? In children over 1 year of age, ureteric reimplantation with or without ureteral tapering is considered the gold standard, but in younger patients, reimplantation of a highly dilated ureter into a small bladder is challenging and can lead to potentially serious complications. So many authors still prefer to perform a temporary urinary diversion prior to definitive ureteral reimplantation. Other options are reflexive reimplantation, temporary endoscopic stenting with or without prior dilatation. Endoscopic high-pressure balloon dilatation of the vesicoureteral junction was described by Angulo in 1998 as initial management of complicated primary obstructed megaureter. The initial management of primary obstructed megaureter with minimally invasive and urological treatment has been gaining popularity in recent years. Since then, multiple publications have shown that endurological dilatation is feasible and safe, minimally invasive technique for small patients. And in recent years, interest has focused on the long-term effectiveness of this procedure, and it seems that dilatation could be a valid option as a definitive treatment for primary obstructive megaureter. Now, we are going to describe the high-pressure balloon dilatation technique step by step. Under general anesthesia, the ureterovesical junction is bypassed with a 0.014-inch flexible hydrophilic guide wire. The ureterovesical junction is dilated with a low-profile 6 mm or 7 mm balloon catheter, which passes over the guide wire and is filled with radiologic contrast medium. The ureterovesical junction is dilated at 14 atmospheres for 3 minutes under endoscopic and fluoroscopic control. We can see a narrow ring initially at the ureterovesical junction of the primary obstructive megaureter, and we can observe the disappearance of this narrow ring. Here we can see it. And then we deflate the balloon. And after deflating it, we introduce the cystoscope to assess the ureterovesical junction here and also the distal ureter. Finally, a 4.8 French double J catheter is left in place. We also leave a vesical catheter during 24 or 48 hours, depending on the postoperative hematuria. We usually remove the double J catheters 2 months later under general anesthesia. Oriol will talk about this topic later. And we reassess the ureterovesical junction passing the cystoscope through it. In case of recurrence of stenosis, a new dilatation is performed. We use a 9.88 French compact cystoscope with a working channel of 5 French. As you have seen, this is a simple, easy, and reproducible procedure, but the key point is to have the appropriate material. Here we store ours. And this is the 0.014-inch flexible hydrophilic guide wire. These are the low-profile 6 mm and 7 mm balloons, and this is the inflation device. Follow-up consists of ultrasound at 3, 6, and 12 months postoperatively, and voidance hysterectography and diuretic rhinogram at 6 months. So thank you very much for your attention. You can send your questions and we'll be happy to answer at the end of the webinar, but please don't leave yet because the best is yet to come.
Good evening. My name is Oriol Martín-Solé, Pediatric Urologist at the Pediatric Surgery Department of the Sant Joan de Déu Hospital in Barcelona. Thank you very much for the invitation and the opportunity to present our results. As Dr. Sonia Pérez explained before, for more than 15 years, our team have been performing endoscopic dilatation as the treatment of choice in all patients with primary obstructive megaureter. During all this time, we have carried out a prospective data collection in these patients. In this study, we have included the patients who underwent a dilatation until December 2021 to be sure that all patients had been followed up for more than 1 year. Regarding the data collection, we collected patients' demographic data as age and gender, preoperative characteristics of the patients like the megaureter site, the ureter diameter, the pelvis diameter, the presence of parenchyma thinning, the hydronephrosis grade, the preoperative differential renal function, the surgical indication, and the presence of paraureteral diverticulum. We collected the surgical details as well, like the balloon diameter, because we use balloons of 6 or 7 millimeters, and the time until we remove the JJ stent. And finally, the outcomes at follow-up, which consist of the probability of success or the need for surgical reintervention. In fact, we have divided this study into two different outcomes. Outcome number 1, the need for surgical reintervention. It is the need for megaureter dilatation, the need for reflux endoscopic treatment, or the need for ureteric reimplantation. And outcome number 2, the failure of endoscopic treatment, that is the need for ureteral reimplantation. We performed the balloon dilatation on 55 ureters of 50 patients. And these are the patient's characteristics. Surgery was performed at an average age of 13 months, and 82% of the patients were male. The majority of megaureters were on the left side and had a thinning on the renal parenchyma. The main surgical indication was hydroureteronephrosis worsening, followed by infections and function impairment. We use 7 millimeter balloons in 76% of patients and removed the JJ stent in a mean time of 53 days. So about the first outcome, we had a 51% success rate with balloon dilatation without the need for further surgery, either open or endoscopic. And comparing the groups, patients in the groups in the failure group were younger than patients in the success group. As you can see on the figure on the right, we also found that megaureters of the right side had a higher risk of needing reintervention than megaureters of the left side. And the risk of reintervention was also higher in the presence of a bladder diverticulum. Comparing according to the type of surgical indication, we found that the risk of reintervention was lower when it was indicated for urinary tract infections. We did not find differences according to the balloon diameter, but we did find differences according to days of JJ stent. As shown in the figure, surgery was more successful if the JJ stent was maintained longer, 60 days versus 47 days. In fact, removing the JJ stent before 55 days had 4.5 times more risk of reoperation. We performed a multivariate analysis to detect independent risk factors for reoperation, and we found that the days of JJ stent and the indication for surgery due to infections were protective factors, while performing surgery on the right side and in kidneys with parenchyma thinning were risk factors for surgical reintervention. So in conclusion, taking into account the need for both open and endoscopic reoperation, the global need for reintervention was 49%. There was a tendency to ureter failure in younger children, less failure if the surgery was indicated due to UTIs, higher failure on the right side, a tendency to ureter failure if there is a diverticulum associated, and less failure if the JJ stent is left longer, especially more than 55 days. I think it's very important to note that of all this, the only variable we can actually control is the time of JJ stent, and that every extra day the JJ stent is left on place, the risk on reoperation decreased 6%. Now we're going to analyze the results of outcome number 2, that is the need for ureteric reimplantation, but excluding the need for a new endoscopic treatment. In this case, the success rate is 63%. The probability of success continues to be lower in younger patients and in case of bladder diverticulum, and it's more likely to be to need a ureteral reimplantation if the dilatation is indicated by hydroureteral nephrosis worsening, and less likely if it is indicated by UTIs or function impairment. There were no differences according to the balloon diameter, but there were still differences according to the days of JJ stent. As you can see on the figure on the right, more days with JJ stent mean more success and less risk of needing ureteral reimplantation. So again, a JJ stent left in place for less than 55 days increased the risk of ureteral reimplantation nearly 5-fold. We thought that perhaps those patients with a postoperative stent infection were the same ones who needed more reimplantations and at the same time wore the stent for less time. So in order to rule out a bias due to a JJ stent infection, we decided to repeat the analysis, but only taking into account those patients without a JJ stent infection. And again, as you can see, the days of JJ stent were higher in those patients who did not require a reimplantation. For outcome number 2, when performing the multivariate analysis, we found that more days with JJ stent were a protective factor for reimplantation, and that indicating surgery because hydroureteral nephrosis worsening was a risk factor for reimplantation. So in conclusion, the global need for ureteric reimplantation in our patients was 37%. There was a tendency to more need for reimplantation in younger children, and if there was a paraureteral diverticulum associated, there was more need for reimplantation if the surgery was indicated for hydroureteral nephrosis worsening, and less for UTIs or function impairment. And finally, there was less failure if the JJ stent is left longer, especially more than 55 days. So again, I think that the most important thing is to note that of all this, the only variable we can control is the time of JJ stent. So as an important take-home message, we recommend maintaining the JJ stent between 2 and 3 months, or at least more than 55 days, because it could reduce the need for surgical reoperation, especially the need for ureteric reimplantation. Thank you very much. If you have any questions.
Thank you. Just while you're typing in your questions, we will do 2 more polls just to see what you learned from this webinar. First, after this webinar, would you perform HPDP as a first line of treatment for POM in case of failure of conservative management? So we see that 81% would do this. The last question, In case of performing a high pressure balloon dilatation, how long would you keep the double G stent? So, 74% would say more than 2 months. Thank you very much for your answers. We do have a few questions. I don't know, Sonia and Oriol, can you see them or should I read them out loud?
Yes,
I cannot see them.
we can see. Yes.
Okay.
We have, first of all, one comment. Guadalupe Colucci says, thank you very much for the excellent presentation. So thank you, Guadalupe, for your words. Then she asks if we still perform dilatations when we have paraureteral diverticulums. And yes, that's right. We still perform the high pressure balloon dilatation in those cases, even if we know the percent of success is lower. But we are aware in the postoperative follow-up, and at least we try to perform the definitive ureteral reimplantation in case it's needed when the patient is bigger, so with much guarantee of success, and we avoid urinary diversion in the newborn. Then Antonio Cutrupi asked us, at what time after birth do you perform renal and bladder ultrasound? In our hospital, we use performing at 7-9 days after birth. Thank you. So we ideally perform the first ultrasound after 72 hours of life in order to avoid the physiologic dehydration period of the newborn that could have underestimated the measures of ureterohydronephrosis. But sometimes the pediatricians perform the first ultrasound earlier. But then we repeat them ideally after 1 week of life, and then in the follow-up, if it's needed, at 1 month. I don't know if there are more questions or comments.
I have 2 more questions to Oriol. Can you see them, Oriol?
Yes. Emmanuel Trabaluski, sorry, asks in how much time we can retreat endoscopically an eventual relapse of stenosis. Well, we perform an ultrasound 1 month and 6 months later, and repeat the renogram at 6 months. So normally at 6 months later, we can see if there is still an obstructive renogram and persistence of dilatation in the ultrasound. So normally 6 months later, we can see the results. And if we have any doubt, we can wait until 1 year or more. And then Dr. Romy Gander, Bayebron, asks which technique was used for ureteric reimplantation, and was it open or minimally invasive? We normally use an open approach, a Cohen reimplantation, and if it's needed, with a plasty of the ureter, of the distal ureter. I don't know if there are more questions.
Yes, there are a few more. I tried to send a few to you and a few to Sonia. And Sonia, perhaps you could answer a few.
Yes. Thanks for presentation. What's about antibiotic prevention and how long do you use antibiotics after balloon dilatation? From Joseph Karensak. So we use the antibiotic prophylaxis during the double J while double J is in place, and we usually use amoxicillin with clavulanic acid or cotrimoxazole. And other question, Dr. Antonin Proza, did you see any grade 3 or worse claving dingo complication after high pressure balloon dilatation? Any nephrectomies? What was your rate of UTIs with JJ in situ postoperatively? So we don't have any nephrectomies in this series regarding to the high pressure balloon dilatation, and no grade 3 or worse complications. The worst complication should be to can't perform the procedure because we can have some technical impairments, or the megaureter is too thin even for the low profile balloon, and we have to do another procedure as reimplantation. Other questions, Simona Gerocarni?
The risk of UTI, I think it's like with the JJ stent, it's about 20%.
Yeah, I'm sorry, I was missing question. So Simona Gerocarni, in case of failure, when do you decide to perform a redo high pressure balloon dilatation, and when do you go for a reimplantation? Do you have an algorithm? So we usually decide to perform a redo dilatation when we are going to perform the withdrawal, the removal of the double J stent, and we check the ureterovesical junction, and it's not wider enough, so we redilate. And in cases we can't perform initial the procedure, or we have a complication that concerns us too much, or is a parureteral diverticulum, sometimes we decide to go to the reimplantation.
When there is a reflux associated as well, because we perform voiding cystourethrogram at 6 months, and if there are reflux associated, we perform a reimplantation.
And this is always a high-grade reflux because you have a dilated system.
Yes. Regarding this, we have one question of the audience. Sarah Chenot, sorry if the name is not correct, asked if we use this technique for the refluxing obstructive megaureter. The answer is no. We don't use this technique if there is a refluxing megaureter, refluxing obstructive megaureter. We use a reimplantation, an open reimplantation. And I have another question from Marcelo Carlucci. Could you better specify the patient selection for dilatation, as there could be different types of megaureter, East as long tract megaureter? The selection of patients is when there are a megaureter with an important dilation of the distal ureter and an obstructive renogram, and there are associated or lessening of the function, or decreased function, or UTIs, or the dilatation is worsening. And we include in this, we try to perform a dilatation in all these patients, and it is true that in, I think, maybe 2 or 3 patients, we could not perform the dilatation because the we could not catheterize the union, and this is like I think in 2 or 3 patients, no, Sonia?
Yes, that's right.
But in the all other patients, we could perform this technique. And I have another question from Simona Gerocarni. How do you define a failure of high pressure balloon dilatation? In this study, we considered a failure as the need for a reintervention. If there is no need for more treatments like endoscopic or open treatments, we consider the procedure a success.
So regarding this last question, we have another one from Dr. Garcia Aparicio that says, our results are worse than other centers' results. Why do you think we have that numbers? So I think because we have the selection of cases very strict. Also, our follow-up protocol, as we do renograms and cystographies to all patients. So there are other series that don't perform that, and sometimes we perform failures. We say we have failures that other centers don't know, and also we are.
If there are reflux, high-grade reflux, and it's maintaining in the time, we decide to reoperate. But there are centers that does not perform the cystogram, so they don't know if they have some high-grade reflux.
Yeah. And other question from Ignacio Mirón. I would like to ask, how do you decide to perform a radioendoscopic dilatation at the time of the double J removal? Is it in case the cystoscope doesn't go through the meatus? Yes, that's right, because it's like a calibration with an 8 French diameter when we perform the removal of the double J. And if it's too much fibrosis and then don't progress, we repeat the procedure.
I have a question from Phoebe Ul. How well are JJ stents tolerated? Normally, they are well tolerated, but in some patients have like discomfort with during the micturition, or and then if it's the case, we recommend to treat with anticholinergics. We used solifenacin. And another question from Phoebe as well. How long is the hospital stay? Normally 24 hours. We leave a vesical catheter, normally 24 hours, in some cases 44 hours, depending on the grade of hematuria. Then we remove the catheter and discharge the patients.
So we have another question from Miguel Garcia. Which criteria do you take in account to determine failure of dilatation? infections, persistence of stenosis, decrease of renal function when you advise a scintigraphy. So in this study, our criteria to determine failure of the procedure is the need of a secondary procedure that could include all the other things you have already said. Other question from Johan Rinaldo. Is there any risk of reflux after high pressure balloon dilatation? Yes, you have the risk of a secondary vesicoureteral reflux, as we explained before, and it's about 20% of the cases. You have more questions, Oriol?
I have a question from Gabriel Nonenmacher. How do you perform balloon dilatation in ectopic ureteral opening? Normally, if there is an ectopic ureter, this technique is contraindicated. So if there is a ureter and an ectopic ureter, like in the urethra or the neck of the bladder, then we do not perform this technique. And a question from Sarah Chenouf. What are the criteria for a second dilatation? The criteria is when we remove the JJ stent, then we try to introduce the cystoscope inside the ureter and see the widening of the ureterovesical junction. And if it's wide enough, then do not perform a secondary dilatation. And after that, we check at 1 month and 6 months with ultrasounds and with renogram at 6 months. And if there is a persistence of important dilatation of the ureter and an obstruction, then we decide to perform a secondary dilatation after the removal of the JJ stent.
We have more questions here from Marcelo Carlucci. Is there any intraoperative finding to shift from dilatation to reimplantation, not only the impossibility to pass the guide wire, the impossibility to pass the balloon, but the rest of intraoperative findings, not yet, not yet.
Well, if there is diverticulum and the ureter ends inside the diverticulum, then it's impossible to form the.
So difficult
and if the ureter is ectopic as well.
Yeah. Even we have passed some double J stents in ectopic ureters to avoid performing a too early reimplantation, but not thinking in a definitive procedure as with primary obstructive megaureters. And we have other questions from Simona Guerro-Carni. Thanks for the beautiful presentation. Till what age do you recommend high pressure balloon dilatation? How old was your oldest patient? So we usually start with high pressure balloon dilatation as the first indication. And I think the oldest patient was 13, Oriol?
The mean age was 13 months. Yes.
But the oldest patient? I think it was 13.
I can check in the meantime.
Yeah. Okay. So another question from Ermelinda Melen. Do you perform reimplantation for reflux also in patients asymptomatic? Thanks for your presentation. So usually for symptomatic is easy to establish the indication, and for asymptomatic, depending if it's a high-grade reflux, in these cases, if you have a secondary reflux, it should be, or if you have a progressive dilatation or ureterohydronephrosis with parenchymal thinning or other or symptoms, for sure. In asymptomatic, we usually wait because sometimes the initial reflux during the follow-up disappears. And there are other cases that have been treated with endoscopically as well, but generally we perform reimplantation for high-grade reflux or symptomatic patients.
I have checked, and the minimum age was 1.3 months, and the maximum was 8.5 years.
Okay.
And I have another question from Sarah Chenov. Your opinion about the dilatation without JJ stents. Same results, same efficacy. Well, we always leave JJ stent, so we cannot compare without a JJ stent. But it's true that a few months ago, a friends group of Dr. Leclerc of Nantes published an article in the Journal of Pediatric Urology about the efficacy of the high pressure balloon dilatation without a JJ stent. And surprisingly, the results was very good, and the success was nearly 80% or 75%, 81%. So I don't know why the results. Maybe the selection of the patients were different. Maybe we check if there is a postoperative reflux, and we treat the high-grade reflux if they doesn't resolve in the follow-up, and maybe they do not, and they leave high-grade reflux without knowing it. I don't know the difference of maybe the follow-up of the patients is different. Maybe the selection of the patients to perform the surgery was different as well.
We have another question here from Jose Moreno. Do you have any experience using the cutting balloon for a second dilatation? So we don't use the cutting balloon, so we don't have any experience, neither as first dilatation or second, or even other cases as a dilatation for retroperitoneal fibrosis or oncologic cases. So we don't have any experience. Other groups as Gregorio Marañón that have used, they report less dilatation using the cutting balloon than the high pressure balloon dilatation. So I think we are not going to use in the future, but who knows?
Mm-hmm. I remember one case that we could catheterize the union and pass the balloon, but the union was impossible to dilate. with the balloon. So in this case, I would have liked to have a cutting balloon in this case, but we do not have it. I have another question from Marcelo Carlucci. Do you manage post-dilatation reflux by sting or reimplantation? Well, normally with reimplantation. In some cases, if the reflux is it's not a high-grade reflux, then we can perform an endoscopic treatment. But normally, the reflux it's a reflux in a very dilated ureter, so we decide to perform a reimplantation.
Thank you very much, and thank you for answering all these questions. For the audience, thank you for your engagement and for asking all these questions. If there are any questions left, I will send them to our presenters by email. So I would like you all very much for joining us tonight. And of course, Sonia and Oriol, thank you very much for doing this wonderful
Thank you very much for all of you. Goodbye.
The webinar has been recorded and will be available on both our GoToWebinar platform and our YouTube channel, and the links will be sent tomorrow. All links for previous sessions are on our website, as are the details of the forthcoming webinars. And finally, all of you who've attended today will also receive a survey immediately after the session finish. We would be very grateful if you could spend a few minutes filling it in to help us improve further session. So for now, thank you very much, and I wish you all a very good night.
Okay, thank you very much.
Thank you.
Bye.
Bye.
Bye.